Hello, my name is Ben Johnson and I'm an advanced clinical practitioner in gastroenterology at the University Hospitals Birmingham NHS Foundation Trust. And I'm presenting this poster on behalf of myself and Dr. Vanya Guljaka, who is a consultant gastroenterologist also at University Hospitals Birmingham. So the title of this poster is The Effect of Bowel Preparation in Patients with and Without Chronic Kidney Disease, and it's a retrospective audit of 1,000 colonoscopies. So as we know, adequate bowel preparation with a laxative agent such as polyethylene glycol or PEG prior to colonoscopy is essential to allow us to get good views and ultimately to complete successful procedures. But in our trust, prior to receiving such a laxative solution, patients would sometimes undergo blood sampling to look for evidence of chronic kidney disease. They may also have blood taken following colonoscopy to recheck their renal function to look for any evidence of renal impairment or acute kidney injury following the bowel prep. Now, in the past, there have been concerns over potential electrolyte abnormalities and dehydrating effects that these types of bowel preparation can cause. However, the vast majority of literature around the use of these agents would suggest that they are safe in patients with CKD. Therefore, we decided to undertake an audit to look at the practice in our local departments to see whether or not blood sampling routinely is necessary or not. So what did we do? We audited 1,000 patient records for individuals that had undergone a colonoscopy between January 1st and December 31st, 2017, and had received 2 litres of PEG solution prior to the procedure. We included patients with serological evidence of CKD and without CKD. For the purposes of the audit, patients with CKD were defined as those with an eGFR of less than 60 litres per minute for more than 3 months. So the aims overall were to try and find out whether or not routine blood sampling prior to colonoscopy is required in patients that are receiving this type of prep, and to essentially compare the difference in the effect of bowel prep on the renal function in patients, both with and without CKD. So on examination of the records, we determined that only 20% or 209 patients had had blood sampling before and after colonoscopy. So 20% of the total 1,000 records. 58 of these had evidence of CKD and 151 of them did not. We then went on to calculate the mean creatinine and eGFR values for the patients with CKD and for those without. And we looked at the results before and after receiving the bowel prep. We then calculated a change in the percentage between the pre and post preparation blood values. Statistically, we used the Mann-Whitney U-test to look for evidence of statistical significance in the percentage change in both creatinine and eGFR in the CKD compared with the non-CKD groups. And overall, our results demonstrated that whilst there was a small change in the creatinine and eGFR in both groups, the difference did not reach statistical significance. Furthermore, the 5 patients in the CKD group with an eGFR of less than 30 showed no significant impairment in their overall renal function following receiving the prep and colonoscopy. Therefore, what our audit demonstrates is that the administration of 2 litre of PEG solution in patients with CKD is safe, and that routine screening for CKD prior to receiving this prep and undergoing colonoscopy is probably not required. Thanks for listening.